We're going to examine the loss as a result of the death of embryo, a fetus, and a neonate this time. We need to be aware that there's so many non-death losses during this stage of life, such as infertility, assisted reproduction, abortion, adoption, and the learning of a fatal anomaly. We'll talk about how these losses impact people biologically, psychologically, socially, and spiritually. Then I will introduce some interventions that are proven effective for this population and issue. We'll kick off today's class with the activity online. You can participate in the discussion forum titled Reflection Activity. Here's a list of prompts you would respond to, and you can also ask your colleague questions or comment on their responses. What are your own beliefs about the nature of an embryo or fetus? How may this belief inform the work you might do with women and their families after pregnancy loss? First, I want to share some facts about pregnancy and perinatal loss with you so that we can have some overall understanding of it. According to the National Center for Health Statistics, about 1 in 100 pregnancies ends in stillbirth. This estimated rate of ectopic pregnancy in the general population is 1 to 2% and 2 to 5 among patients who utilize assisted reproductive technology. Empirical research finds that overall rate of pregnancy loss in IVF and ISI clinical pregnancies is up to 12.5%. Pregnancy involves the development of the fetus, from multi-celled blastocyst through umbilical stages into a fetus that is eventually capable of living independently, and the development of the woman, from an individual through a pregnant woman through a mother with responsibility towards another person. For practitioners, we should be aware that the whole process of pregnancy involves so many poorly recognized losses. Even in ideal circumstances, a planned pregnancy, lovingly accepted by prepared parents and their extended families, who traverse pregnancy and delivery with no real complications, people still experience losses. The woman lost true independence in that she must consider how her self-care and nutrition affect her pregnancy. She loses sleep, her non-pregnant body, and possibly her sense of autonomy. Her partner may feel the similar loss of independence, as the partner is now tied more tightly to the pregnant woman and may be relied upon more extensively for economic, emotional, and other support. Although those losses are generally welcomed as a sign of maturation. From a theoretical perspective, pregnancy and perinatal attachment frame the experiences of any losses during the perinatal and pregnancy time. We need to understand the historical changes of pregnancy and perinatal attachment. It is now viewed as expected where previous generations did not begin to attach before quickening. This change happened due to the medicine and technology advancement. People now can see and hear the fetus at early stage of pregnancy. A pregnancy impacts a woman biologically, psychologically, socially, and spiritually. Hormonal changes in the woman's body cause breast tenderness, bloating, and nausea. It also leads to emotional effects such as increased irritability, lay-by moods, and increased sense of vulnerability. These changes are biological source where the attachment is formed. We recognize depression and anxiety symptoms are common during typical pregnancy and even more likely during high-risk or medically complicated pregnancies. Levels of stress are particularly high when the mother has had a prior pregnancy loss. Research finds that women have experienced pregnancy loss often try to avoid early attachment so that they can protect themselves emotionally. We need to know that social contexts powerfully shape pregnancy and birth. Our cultural heritage and religion influence our expectations, attitudes, and practices regarding pregnancy, beliefs about fetus and childbirth. Failure to adhere to given social norms brings sanctions from family members, friends, and medical care providers. In sum, pregnancy and the prenatal stage bring joy and challenge to women and their families. Social workers are called to assist in this transition for all women, particularly for those experiencing death losses. Before we begin to talk about scientific findings regarding the biopsychosocial reactions to pregnancy and perinatal loss, let us watch a TED Talk video and hear the story from a woman who experienced pregnancy losses. You can find this video clip in Canvas titled Breaking the Silence of Pregnancy Loss. The experiences of miscarriage, intrauterine fetal death, and other pregnancy losses lead to abrupt change in the biological status of the pregnant woman. For instance, hormone levels drop dramatically. The hormonal and other metabolic changes happen regardless whether the fetus is born alive or not. The drop in hormone levels also creates propensity towards depressive moods that the pregnancy loss will exacerbate. Before the early 20th century, women seldom responded very emotionally to an early miscarriage, as these were very common, and childbirth threatened women's health. Nowadays, perinatal death loss have become more recognized as a source of psychological pain. The psychological effects of perinatal loss may last. Research reveals that it is strongly tied to anxiety and depression even up to 10 years after the loss. Race, class, religion, and ethnicity all have a bearing on how perinatal attachment is viewed and how perinatal grief is enacted. With the multi-factor thinking in mind, social workers also need to pay attention to those who are marginalized and bereaved. For instance, research indicates that African American parents have a higher rate of pregnancy loss overall. They have more accumulated stress in form of marginalization and oppression over their lifetimes, and they typically adhere to cultural norms that encourage continued bond with the deceased and greater emotion expression, but less overt familiar dialogue about grief and loss. Lesbian couples often find to experience complex grief reactions more frequently after perinatal loss. Their severe grief is associated with their experiences navigating so many barriers to pregnancy and dealing with disapproving social contexts. Family members are affected by perinatal losses as well, and some of the forgotten grievers are living siblings. Research informs that the lifelong effects of perinatal loss on siblings, they will likely have raised anxiety and worry about their parents' health and coping, and feel like that they are not enough for their parents. Research finds interventions such like avoiding family secret keeping and promoting rituals such as scrapbooking and other memorialization can assist siblings in coping with perinatal death. On the list of forgotten grievers, we often see grandparents. They're not only mourning the grandchild that will not join the family, but also grieving for their son and daughter. When working with the entire family, social workers need to include grandparents and pay attention to the losses they have experienced and accumulated in their lives. The absence of rituals for enlisting support and saying goodbye in perinatal loss makes this loss drastically different from other types of death loss, where funerals, memorial service, and social support are very common. Research tells us that the lack of ritual often causes additional or prolonged stress for those who suffer this loss. Like the lack of ritual for perinatal death, the social recognition of the loss due to a fatal anomaly is insufficient as well. Social recognition of this loss is complicated even further since the pregnancies are electively terminated. Practitioners need to recognize the stigma associated with abortion in our culture and validate the client's feelings of loss. To sum up, perinatal bereavement is experienced and expressed in a variety of ways, influenced strongly by social norms. The level of perinatal attachment has much to do with the way the loss is experienced and mourned, just as responses and support of friends, family, and healthcare providers are crucial to how the bereaved parents grieve. Only a full biopsychosocial spiritual assessment prepares the clinician to practice competently, sensitively in such cases. Before we move on to talk about interventions for this group, let's spend some time recognizing some other types of perinatal losses that are not death-related. Some examples are loss of ability to become pregnant. Infertility is estimated to affect 7 to 50.5% of eligible women, meaning the women who are trying to get pregnant in developed countries. And the rate of infertility has been rising as more women want children at the age beyond their optimal fertility. People began to visualize their hopes for pregnancy long before they pursue it. Infertility invalidates these expectations and creates a sense of vulnerability, a loss of self-esteem, and belief that one's body is defective. Loss due to unintended pregnancy. Risks of unintended pregnancy vary by age, race, and educational status. According to the Guttmacher Institution's data in 2019, about 45% of pregnancies were unintended in 2011, and 42% of the unintended pregnancies ended in abortion. Social workers should be able to identify the barriers in the client's social and political reality. In the case of unintended pregnancy, when it yields to the decision to abort, accessing reproductive health care services can become part of the stress, because it's highly stigmatized, and multiple states now have passed laws to make abortion service essentially inaccessible. Empirical research also finds that adoption can leave the birth parents with grief, lower sense of self-worth, and other painful emotions. These types of loss and grief are unlikely to be recognized as well. Medically complicated pregnancies and loss. Complications occur 10 to 20% of pregnancies in developed countries, and conditions like premature labor, pregnancy-induced diabetes are among them. Women experiencing these conditions experiencing loss of control, both because their bodies are not behaving in the ways they would choose and because required medical care limits autonomy. In the United States in 2010, approximately 1.5% of all births are due to assisted reproductive technology. While the technology helps many to achieve their dreams of pregnancy, it brings feelings of loss at many levels, such as loss of sense of body integrity and function, the loss of embryos, and the loss of innocence about the natural ease of creating a family. In addition, losses due to birth very premature children after reproductive technology are induced are very common as well. On the macro level, the empirical finding indicates that OBGYN providers seem unfamiliar with resources of psychosocial interventions for perinatal grief. It informs that we need more interdisciplinary collaborations. On a macro level, any psychosocial intervention could start with clear, empathic, tailored explanations of the loss. Additionally, parents are found benefit from opportunity to build memories of their child's brave life and need adequate information about varied delivery and burial options. My colleague developed a framework for interventions for youth with perinatal loss. It's called the 5 V's. The 5 V's are validating, valuing, verifying, ventilating, and being visionary. They provide a model to structure the work, yet allow the bereaved to follow their own needs and inclinations Social workers can use it to guide the work without resorting to structured, predetermined tasks. Here's a brief introduction to it. Number one, validate the loss. We need to acknowledge that the loss they experience is a loss. Particularly when pregnancy has not been revealed, the bereaved parents may not have others acknowledge their loss. Helping the women and couples recognize their right and necessity to mourn is a crucial first step towards healing. Step number 2 and number 3, valuing and verifying, are elements of validation. By recognizing the lost entity that have value to the mourner, the practitioner validates the griever's right to mourn. Helping the bereaved parent discuss all aspects of the lost entity person's value, acknowledge the importance of the disrupted bond. Verifying includes any intervention to assist the bereaved with gathering tangible mementos or developing rituals that make real of the loss. These reminders can be used by parents to stimulate support from friends and family. Creating memory boxes with footprints, handprints, locks of hair, and pictures, if possible, is useful to parents' own grief, but can also be used to remind others that the baby had a presence in this world. Ventilating entails an expectation that the bereaved are able to talk about the loss with authenticity, consistent affect, and content, and such mourning does not require tears. In pregnancy loss, gender stereotypes of mothers mourning with tears and fathers with rigid control often hold true, but not always. Ventilating may lead to meaning-making, and social workers can help explore many ways the loss has affected the griever's life. A grief therapist often practices best by remaining quietly supportive and exploratory, avoiding platitudes or trite phrases that could interrupt the mourner's ability to ventilate thoughts, feelings, and reflections freely. Being visionary entails assisting the bereaved person to think through likely future events and recognize their potential for intensifying grief feelings. It is often part of the ending process, but occurs throughout the work with the bereaved. In being visionary, the social worker can share lessons learned from others about when and where grief is likely to be heightened. With the perinatal loss, the due date for lost pregnancy often revives the feelings of grief. Grievers often need to reflect and mourn at this time. Likewise, helping the perinatally bereaved anticipate the future pregnancies are likely to be fraught, with reminders of the loss can help them recognize and manage anxiety if that comes to pass. Interventions in perinatal grief will nearly always require attention to the disenfranchised nature of nearly all of its forms. It also incorporates awareness that parental grief differs from other types of grief due to the grieving parent's sense of responsibility for the offspring's well-being. No intervention in perinatal grief is complete without attending to these issues. This will wrap up our session today, and please participate in the session's literature review and case study discussion. Let me know if you have any questions. I will see you next time.